Good evening to everyone who is joining us for tonight's webinar. I want to thank NAMI Helena for collaborating with our task force and providing the technical and financial assistance to make this webinar possible. Joining us tonight for our panel discussion are Dr. Robert Caldwell, psychiatrist and medical director for the Florence Crittenden Recovery Home, Pam Ponich-Hunthausen, LCPC therapist, private practice, working with children and parents for the last 28 years. Kelsey Kyle, RN, care manager, St. Peter's Health Medical Group. Stephanie Morton, program manager, Healthy Mothers, Healthy Babies. And Sheri Walker, survivor. The title of our webinar borrows the hashtag MomsAreNotImmune from the 2020 Maternal Suicide Awareness Campaign. Many mothers suffer in silence from perinatal mood and anxiety disorders, which can lead to tragic consequences. Recent studies have found that deaths by suicide account for almost 20% of postpartum deaths. And another recent study found 1 in 20 women in the perinatal period experience suicidal thoughts. Yet, too often, moms have been left out of the suicide conversation. Why aren't we talking about it is one of the reasons maternal suicide remains a silent issue. Our intention for tonight's webinar is to shed light upon this critical subject and to combat the stigma around mental illness and motherhood. So welcome to everyone. I'm going to begin tonight's conversation with Stephanie Morgan, program manager, Healthy Mothers, Healthy Babies. Good evening, Stephanie.
Good evening, Dana, and to everyone else that's on.
Okay, Stephanie, please tell us about your work at Healthy Mothers, Healthy Babies and your role in writing the brief addressing suicide in the perinatal period.
Sure. So I serve as the program manager for Healthy Mothers, Healthy Babies. I've been there for a little over 2 years now. And for those who might not know, Healthy Mothers, Healthy Babies is a small but mighty nonprofit that serves folks statewide. And we work closely with a lot of other family support organizations, so a lot of direct support organizations, including public health departments, hospitals, mental health providers. And our mission is really just to improve the outcomes in that prenatal to 3 age range. And perinatal mental health is one of our areas of focus. What led me to write the brief on addressing suicide in the perinatal period was really doing some deep research and struggling to find information and realizing, our state is consistently has the highest rates of suicide. And this is something that's been a focus of many, different grants and campaigns. And I thought it was very odd that I wasn't able to really find much specifically about maternal suicide in the perinatal period. So I started doing some digging around that, and what I learned just felt like it needed to be told. And so I just worked out that brief, and yeah, it was mostly just to solidify my learning and then be able to show other people and say, can you believe this? So yeah.
There I am. It's an excellent brief. And I would just want to, you wrote in that brief that suicide in the perinatal period is understudied and not well researched, and you talked about that, and not well understood. What do you think the reasons are for the lack of research and the lack of understanding on this topic?
I think one of the first places that we have to start is with our comfort or ability to engage with a difficult topic. There's a saying, what we measure is what we change, what we pay attention to is what we affect. And I think that one of the things about, engaging in research on suicide or suicidal ideation it's very difficult to see the numbers and also understand the impact behind the numbers. So not only are we talking about the topic of suicide, which has a lot of social and cultural and emotional implications that vary for many, many different people, but we're also talking about that specifically with moms. And when we even narrow that in even more to that perinatal period, which includes that pregnancy and then the first year postpartum, really there's a lot of misperception or belief, social pressure to think that is one of the happiest times in people's lives. And I think that many moms can relate to that piece. And I think many caregivers can relate to that. And so when you're trying to talk about maternal suicide, it becomes very difficult to engage in those conversations. And so that also plays out in how we collect data or how we don't collect data more aptly. I think that one of the bigger barriers to actual data collection is that in our state, suicide, and that's done so by coroners, and in many places, coroners are maybe not required to have medical training within that. And they also may have social pressures of understanding what it looks like to rule somebody's death as suicide. We all know that hiding things or keeping things private or secret in a very rural place is fairly difficult. And so there are also social pressures on people who are recording that data as well, and that can't be, I think that needs to be highlighted as well. So those are some of the ways that this is pretty difficult to get a lot of hard data out of this.
Okay. And did you find some specific data issues that, I mean, I think you talked to that, the social pressures, the misperceptions of this being a happy time, pregnancy being the most wonderful time in a woman's life. Were there other issues that you found in your research around maternal suicide and our difficulty appreciating it as a national issue, a major issue?
Absolutely. I think the other very leading data collection issue would be the time frame that data is collected and recorded within. So to be considered within the perinatal period, as I just defined it, is kind of the expanded version of perinatal. There are a lot of different measures in maternal and child health that only look to within the first 6 weeks after birth or postpartum. So if we're looking at data and trying to figure out, understanding if a mom has recently given birth, that data is limited to the first 6 weeks postpartum. So really only that first 42 days. Research shows us that the highest likelihood of suicide being completed by mom in a perinatal period is at 9 to 12 months. And so we're completely missing that high likelihood area. And so they don't get recorded as associated with a perinatal period. And that is a really big limitation, not just for Montana, but for I would say all of the states in some manner. That is changing. People are doing work to update some of those data systems. I do think also that there was a pregnancy status box that was also added into death certificate recording, but testing of that in 2017 really revealed that death certificates were not reliably filled out all of the time, and that was a difficulty as well. Yeah.
Okay. And one thing I was thinking of, how do you see what role drug and alcohol abuse or substance use might play in the role of suicide?
Absolutely. So this is a little bit of a sticky area. You know, you can't attribute all overdose or accident, you know, with using substances to also suicide. But we do know that in the state of Montana, from data, that's a really, I think it's 40% of all suicides in the state are alcohol involved. So a death is attributed to suicide, and then folks review that, whether that's a Maternal Morbidity and Mortality Review Board or other review boards in the state, and determine that alcohol was a part of that or a contributing factor to a suicide. So, I mean, that's 40% is a pretty big number.
Yes, yes. And are there any, I mean, I know you've talked a little bit about Montana. Do you have any other specific data about Montana's, what we know about maternal suicide in Montana?
Yes, I can say this, and this actually fits within larger statistics or demographics as well. So while men in Montana are 3.5 times more likely to die by suicide, women are twice as likely to be admitted to an emergency department with a suicide attempt. That fits into other research, which is showing that while suicide is not more common in the perinatal period than outside of that, suicidal ideation actually is. And that, you know, that is something that needs to be, you know, attended to. So while we may even just look at suicide rates, it's important to also look at the ideation data.
Okay. And based on your study, what do you think are the facts about maternal suicide which are important to our understanding of the topic?
Yeah. So knowing that it's, one, we're not measuring it very well, and also that we don't uniformly screen for some of the conditions that are predictive of suicide or suicidal ideation in that perinatal period, and that would include, you know, major depressive disorders. But just knowing that a study of about 10,000 women, this was done in 2013, I believe, found that 14% of those screened for depression, or of those 10,000 women, 14% screened positive for depression. And then within that same 10,000, 3.2% expressed suicidal ideation. And so that's a large number of new moms who are experiencing these symptoms. It's also just, you know, you'll find studies that say that it is the leading cause, and then you'll find other studies that say it's one of the leading causes of death within that perinatal period. And I think at this point, we're kind of splitting hairs. We know it's a much bigger problem than what we have previously believed it to be, and shedding some light on it is a very important next step. Yeah.
Okay, and do you see any opportunities for us or challenges in addressing suicide in our state or in our country? You know, where do you think we need to go with this?
As I'll start with the challenges and then end with what I see as opportunities. I think a lot of the challenges really are about, you know, having consistent screening, and then if we do have folks that are screening positive or we're seeing symptoms that are concerning, making sure we have strong referral resources or resource and referrals pathways to make sure that people are getting to providers that know and understand the nuances of mental health within that perinatal period. I think some of the other panelists will explain some of those nuances, and I think that's one of our biggest challenges. And then also just living in a very rural place. I think probably everybody on here knows that there are limited resources, and particularly limited mental health resources. And whatever we can do in order to improve those, including our crisis response efforts. We can be intentional about putting folks in the perinatal period in those conversations. As far as opportunities, I think some of the opportunities we have is really a very big increase in interest in the perinatal period. Folks in our state are learning more and more, which is fun to see and watch. Screening for mental health disorders increase both in prenatal and postnatal care. I think one of the areas where we have a very incredible opportunity for growth is the fact that we have a very high rate of well child visits. And moms in our state and across the country are more likely to take their children to the doctor than to take themselves to the doctor. And there is protocol from the American Academy of Pediatrics to screen caregivers, all caregivers, for depression at well child visits. And because we have such a high engagement rate in our state, prior to COVID, there's some really great opportunities to expand that kind of screening and care into the pediatric area. And there are many folks who are already doing that. And then conversations like this. So I see those all as very big opportunities.
All right, well, thank you, Stephanie. And
You're welcome.
I will now shift the conversation to Dr. Robert Caldwell, psychiatrist and medical director for the Florence Crittenden Recovery Home. So good evening, Dr. Caldwell. Please tell us about the work you're doing now at Florence Crittenden.
First of all, standard disclaimer, my opinions are my own and do not necessarily reflect those of the Florence Crittenden organization, which is a national organization. We have at Florence Crittenden I think 8-bed transitional living program, which takes young women, teenagers who are pregnant or parenting with very young children, who are in sort of unacceptable social situations, under the custody of CPS, or their kids are under the custody of CPS, they're homeless, or they're trying to get out of a really bad situation. We have a 4-bed recovery home that meets a criteria for a ASAM level 3.1, if you know what that means, but it's residential treatment for substance abuse. I evaluate everyone that comes into the facility. We have the ability to deal with dual diagnosis people that have substance abuse and mental health issues. And I end up, I think, seeing about half the folks on an ongoing basis because of usually some kind of mood disorder.
All right. So in your work at Florence Crittenden, and plus in your work as a psychiatrist in the community, tell us briefly about experiences you've had with mothers who are or have been suicidal. Does anything stand out to you?
We have worked with people who have suicidality. We attempt to make a safety plan with them. We've transported people for hospitalization where we were unable to make a safety plan that we thought would be manageable in the facility itself. I'm thinking of a recent case where a young woman had given birth about 2 weeks before, and her newborn had been hospitalized with breathing problems for 2 weeks. This was the first anniversary that she had sober of a stillborn that she'd had several years before, and she had bipolar disorder. And I was having a lot of trouble figuring out what was the most important factor in her feeling suicidal. She was able to ally with us and remain in the facility, and ultimately seems to be getting better.
Okay, all right. What are the risk factors which contribute to suicidality in women with perinatal mood and anxiety disorders?
So they're the same as the things that contribute to suicidality in anybody. First of all, suicidality is one of the core symptoms of a major depressive episode. The other ones being low energy, depressed mood, not enjoying things, sleep out of whack, appetite out of whack, can't concentrate, down on yourself. And that major depressive episodes occur in major depressive disorder, they occur in bipolar disorder, and they occur in postpartum depressions or perinatal depressions, many of which turn out to be bipolar disorder. But and the suicidal thoughts they're in these clinical or biological depressions are like out of the blue. And the great American author William Styron wrote in one of his books, he's in Europe accepting all these awards for his writing, and he from heads of state up to and including the Pope, and he has a novel that was made into an Academy Award-winning film, and he wonders why the heck he's suicidal. He feels like killing himself. Same thing with it's very similar to what Stephanie mentioned, the young mother who is like, I should be really happy. I've got this beautiful child. I've got my family around me. Why am I suicidal? And there must be something even more wrong with me than I thought. Trauma is a risk factor. Trauma teaches people that they can't trust anybody, that they're not worthwhile. Substance abuse, active substance abuse, the abuse of CNS depressants can cause depression, and I often joke that I can make anybody depressed if they'll drink what I tell them to. And acute substance abuse, particularly alcohol abuse, is disinhibiting. So if you were thinking about suicide, the alcohol can push you over the edge. Hopelessness, a sense of unacceptable or overwhelming loss, having a loss of relationship on top of other losses all at the same time. People who have a lot of anxiety and agitation and insomnia are at significant risk. That increases your suicide risk. Feeling isolated, cut off from others, feeling alone, having a history of suicide attempts, having a family history of completed suicide, death by suicide, and access to lethal means. So having poisons, guns, and ready access to those things. Those are risk factors.
Okay, so I want to just segue back to the role of anxiety in suicidality, and do you see that being particularly characteristic, perhaps, of women who are in the perinatal period, maybe who have given birth, who may have more anxiety, and that can trigger more suicidal thoughts?
So anxiety is extraordinarily uncomfortable and has been referred to as the most uncomfortable bad feeling that we can have. And people just want to escape it. They want to go to sleep. They want to get away from it. And that can drive people to attempt suicide.
Okay. Do you, well, let's go to what are the perinatal mood and anxiety disorders you see and treat in your work? And do you see any relationship with the hormonal shifts in pregnancy, labor, delivery, and the postpartum?
I'm seeing women that are, ages 14 to 30-ish. Most of the perinatal ones I'm seeing are 14, 15, 16, 17. And a lot of those people with perinatal depression are going to eventually go on to develop bipolar disorder. Many of them have family histories of bipolar disorder. And so for technical reasons, I'm nervous about giving them antidepressants, and we'll talk about that later probably. And what was the second part of your question?
The second part of the question was mainly the role of hormones as a result of pregnancy, labor, delivery, and the postpartum.
So I think that there's widespread acceptance that hormones play some role, and that drops in there are high levels of progesterone, especially during pregnancy, that supports the pregnancy, and that precipitous drops in pregnant levels of hormones are maybe a key factor, maybe the most important factor in precipitating a postpartum depression. One of the drugs, brexanolone, has a hormonal action, and to treat postpartum depression, has to be given IV in the hospital. But there's a lot of research interest in this. The only impact on treatment so far has been this relatively recently released medication for treatment-resistant postpartum depression that is based on the theory that hormones are important.
Okay. How do you go about evaluating someone who is suicidal, especially perhaps, I mean, we're talking about women, but how do you go about that evaluation and assessment?
So I'm simultaneously trying to do several things. One is evaluate their risk, the presence of risk factors that we talked about, the presence of mitigating factors. Virtually everyone that is suicidal is ambivalent. Part of them wants to die and part of them doesn't. Can you talk to the person? Can you talk to the part that doesn't want to die and make a safety plan? Is there intent to attempt suicide? Can you provide for their safety, or do they need to be in the hospital? At the same time, I'm trying to ally with them and validate their feelings and give them support and give them the sense that they're not alone and there's some hope. At the same time, I'm trying to figure out what led to these suicidal thoughts and what can I do about it? Can I mobilize their support system? Can I give them some medication? Can I make a plan with them? So, I'm doing all those things at once. I'm trying to sort of make a diagnosis, which guides treatment, of course, and at the same time trying to figure out what their actual risk is and what needs to be done now.
Okay. And so let's just segue in then to the medications that you use to treat perinatal mood and anxiety disorders, especially postpartum depression.
So if I thought that someone had a postpartum depression that was part of major depressive disorder, I would be using an antidepressant. For my adolescence, one of the risk factors several of the risk factors for bipolar disorder are onset of depression prior to age 23, postpartum depressions, family history of bipolar disorder, psychotic depressions. So they've got several of the risk factors already. And statistically, they have at least a 50-50 chance of going on to develop bipolar disorder. They just haven't had time to have a manic episode yet because they're only 15 or 16. So I use a lot of mood stabilizers, and I think some of the child and adolescent psychiatrists wouldn't agree with that, but it feels to me less risky to use a mood stabilizer such as Lamictal or lamotrigine or lithium or quetiapine, Seroquel, than it is to use an antidepressant that if the person has bipolar disorder, it could unmask a mania or a mixed state, which is even more dangerous than a depression, and possibly have an unknown risk of permanently worsening their course of their bipolar illness.
Okay, and I want to just go back to one more thing because I think we haven't touched upon it and I think it's important. What do you think the role of postpartum psychosis plays in the risk for maternal suicide?
People with who are agitated, can't sleep, are frightened, feeling cut off and hounded and having racing thoughts and intractable anxiety are at risk for suicide. So people that are psychotic, many of them are going to be feeling that way. They're going to, it's postpartum psychosis is likely to represent a manic episode or a mixed state. And the mixed states are dangerous because you have the depressed mood of the depressed phase of the illness, but then you have the energy and agitation of the manic phase of the illness. And that's a bad combination.
Okay, and then the role of the psychotic symptoms, the delusional thinking or the hallucinations, are those also part of that?
They certainly can be especially if the hallucinations are commanding people to harm themselves, or if they're persecuting the person and telling them that they're, not worthy, or other people would be better off dead without them. Okay.
I'm going to thank you for your insights tonight and your comments, and I'm going to now turn it over to Sheri Walker, who is a survivor. Good evening, Sheri.
Hi. Hi, Dana.
So, Sheri, as a young mother, you experienced suicidal ideation. Can you tell us what that was like for you?
Sure. So I didn't actually have a suicide attempt, but I did have two very severe suicidal ideation episodes, and I really can't remember too many of the details around like the time frame. I know my kids were a little bit older, they weren't newborn, but so the first one, I found myself very distressed and everybody else was in bed asleep, and I was standing in front of the medicine cabinet, knowing that if I took everything in there, that it could be all the pain and anxiety and distraughtness could be done, and I wouldn't have to worry about it anymore. But I was kind of paralyzed there. I was just standing there looking at the closed cabinet door, and tears just streaming down my face. And I stood there for quite a while, and then I finally was able to get myself to bed. And I don't remember, I've been trying over the last week or so to think about what happened the next day or how I felt, but I can't recall that at all. The second time was much more dramatic and scary than that for me. And again, I don't remember the details leading up to it. I do know that I in the moment, I was not getting along with my husband, so that didn't help anything. But I was feeling really trapped in life, and in that moment, I just needed to get away, and so I grabbed my keys and I got in the car and I left. Just had this urgent, really rash feeling to get away. And we often walked on the path or rode our bikes down by the river, and it was a calming place for me. So that's where I headed. And as I was about to turn off the highway to park, a dump truck was coming towards me in the opposite lane. And I had a split second feeling that I could just pull in front of him. It would look like an accident and it would be all over. And I feel like I had to use all my strength to keep my hands on the steering wheel and keep my car going straight and stopping and waiting for the dump truck to go before I turned. And then I got into the parking lot and I sat there, and rather than going for a walk or anything, I was so shaken that I just sat there, kind of almost in a zombie state. All these thoughts going through my mind, but feeling numb at the same time. And I was probably there for at least an hour, maybe longer. It was dark by the time I got home. And I went directly to bed. It was a Friday evening, and I stayed in bed for the rest of the weekend. I didn't get up except to go to the bathroom until Monday morning. And at some point towards the end of Sunday afternoon, I made a pact with myself that I was going to go and see my provider first thing in the morning, or at least get an appointment with her. And I just felt like a lump of lead, but crying the whole weekend. I wanted to pick up the phone that was on my bedside table and call a friend and just be able to talk to her. But I didn't have the energy or the strength, either mental or physical, to pick up the phone and to call her. And I don't know what I would have said if I had anyway. So it was just, it was very unsettling.
Okay. You talked about those feelings of being overwhelmingly anxious.
Mm-hmm.
Can you describe that in a little bit more, and or what the thoughts were? You said you were having so many thoughts as you were at the river. Just your head was spinning. It sounded like. Were they negative thoughts? Were they?
Well, I think mostly I was scared, but also the thoughts leading up to that would have been, I felt really alone and lonely. I felt like really nobody understood what I was going through. And also I felt very isolated. We were living in Alaska, and I was like 2,500 miles away from my family. I kind of felt like I often said this to my husband, I felt like I was on a hamster wheel, just running and doing stuff, but not getting anything done. And I felt trapped in my, just the sense of hopelessness that it was always going to be this way, and felt really helpless to change it, because it seemed like everything I tried to change, I just kept going back to just feeling really down and horrible.
So Dr. Caldwell mentioned that many people, not just women, but people who are suicidal are often ambivalent. So when you experienced those 2 episodes, did you feel that ambivalence? Did you feel there were reasons for both maybe taking your life as well as for continuing to live?
Oh, for sure. Yeah. So, for just wanting to die was just a means to end the suffering that I felt like I was having. Just all those horrible thoughts and feelings that I was having. But my whole dream was to be a stay-at-home mom, and to, I really desperately wanted to be a happy mom and a happy wife, and I really felt like I would be. Well, my reason for living basically at that time was for my kids, and so that they would not be devastated by losing their mom when they were so little. That was, for me, that was my reason for being.
Okay, so they were your anchor, so to speak, to help you stay grounded, to maybe in not carrying through on your thoughts.
For sure.
Okay. What do you think contributed to that overwhelming sense of hopelessness that you talked about, and that helplessness?
Well, I think possibly the primary reason was I was just exhausted. I was an older mom, and my kids were 16 months apart, and I had a lot of medical issues during that time as well, and I'm a very independent, self-sufficient person, and at that point in my life, being independent and self-sufficient was not serving me well. It was really hard for me to ask for help, which is probably what I needed, but just the lack of sleep was a huge contributing factor.
Okay. In your history with working with providers, were you ever screened for a perinatal mood and anxiety disorder?
No, and as I'm a nurse, and I had worked obstetrics, and during that time, we never talked about postpartum mood or anxiety disorders, and we certainly never screened for them. I actually never heard about screenings until I took my doula training about 7 years ago.
Okay. Do you think it would have been different for you if somebody had screened you, had sat you down and talked to you about the possibility of experiencing depression or anxiety during this time?
I think it probably would have helped me for sure, especially if they had done it in such a way that they made it clear that, they screen for everybody for this, and that postpartum depression and anxiety are very common. And I think it really would have made a difference, for sure.
Do you think there was anything else contributing to the fact that you were suffering in silence around this time in your life?
Well, yes, there's such a stigma about mental health, and so that was probably the biggest thing for me. But also, I grew up on a farm, and just we're strong people, and we just we just push through and get things done. And but I think also for me, there was infertility was an issue, and our children were adopted, and so there was a bit of, well, I was told that I got my babies the easy way, and I will never tell a pregnant person or somebody who is giving birth that that is easy, but it's a whole different ball game going through infertility and then adoption. So yeah, there was definitely some issue there, and I think a sense of shame also, and guilt that I would even have those thoughts. Didn't really want to feel vulnerable, because us type A personalities, we are self-sufficient. We can handle it. And embarrassment. I mean, I shouldn't be feeling this way, right? And especially, I think there's this idea that when you adopt your children, you've been waiting for so long that you should be extra happy because you have these babies, and it's just not that way. There's this kind of conflict between loving your babies and the grief of not being able to bear them yourself. And most people didn't get that. Ironically, my daughter does get that, and I think that's so cool that she does. But it just yeah, I just think that those were the main contributing factors.
Okay. So no one, when you were planning on your adoptions for your children, told you that there was a possibility that you could experience depression at all, that could have been something you would have or experience?
Not really. We were required to attend an adoption workshop, which was a weekend long, and they did refer frequently to this idea of grieving, that it's a loss for the child, because they're losing their birth parent or parents, but also a loss for the adoptive parents because of the infertility issues that I mentioned. But so there was a lot of talk about grief, but it, in my mind at least, it didn't translate to depression and anxiety and to the feelings that I ended up having at a later point.
Okay. What do you think would have been most helpful, or maybe was helpful to you during that time, that would have lessened or did lessen your feelings of being overwhelmed and hopeless?
Well, the standard answer when somebody asks you how you're doing is, "Oh, I'm fine." And I think probably if somebody had expanded on that question and been more specific in their questions, like, how are you sleeping? are you getting enough sleep? Or just asking things like, how are you adjusting to being a stay-at-home mom now? Or do you miss work? And speaking of missing work, I think that was another contributing factor to where I was. I really wanted to be a stay-at-home mom. That was my whole dream. But I didn't realize until I was in it how much I would miss working with other people and having that adult interaction. So I think if people had been much more specific, also, I think having had the mixture of emotions validated for me, just to that other people understood that, yes, I was very happy to have these children, but I was also, there was all these other emotions going on as well. And really those emotions, that mixture of emotions is not, it's not just adoptive moms that go through that. I tell all my students and clients that they can expect to feel, joy, but they can feel grief, they can feel anxiety, frustration, all those other emotions simultaneously. And I think for me, if that had been acknowledged and normalized for me, that would have been a huge help.
Okay. So almost like if somebody had really said, so how are you really feeling, Sheri?
Right.
So,
yeah.
You stated that you never talked with anybody about this except your healthcare provider. What do you think kept you from talking about that experience? And what compels you to talk about it now?
Well, again, it's the stigma is just, and especially, we're getting better about talking about mental health, but back then it just wasn't something to talk about. And for me, there was a sense of shame and embarrassment. I didn't really want to feel vulnerable, but also feeling like, well, I'm a nurse, I should know how to deal with this, which is really pretty crazy because it can happen to anybody in any situation in life. So it doesn't matter what where you're at, it can happen. So for me, that kind of kept me from talking about it. And then I kind of never thought about it, for the longest time either. But it's probably 2 or 3 years ago, I saw the Playing Monopoly with God by Melissa Bangs. I met her at the Lotus and got talking to her afterwards. And then she started emailing me and inviting me to attend her storytelling workshop a few months later. And I didn't feel like I had a story to tell. I wasn't even thinking about my suicidal ideation at that point. It was kind of buried deep in my memory. And I didn't really feel like I had a story to tell. But two years ago, I attended the perinatal mental health conference and attended MomAreNotImmune. And one of the performers' stories really resonated with me. And I realized that, yes, I do have a story to tell. And so I did attend the workshop. I didn't share my suicidal ideation episodes, but shared plenty of other things that were going on at that time. And it really was helpful to me to understand the power of telling a story, not only for my own healing, but also to make myself more relatable to other people and to be able to share with them and help them to understand that they are not alone. And when a person is willing to be vulnerable, it helps other people to open up and share. And so, Dana, when you informed the task force that you were planning to get this webinar together and what you or who you hope to have on the panel, I got this very compelling urge to volunteer, and it actually terrified me for a few days, the thought of sharing. But I just realized if I can at least help one other person, it will be worth being vulnerable. And I suffered in silence, and I don't want anybody else to have to suffer in silence. So that's why I speak now.
Well, Sheri, thank you so much. And we are very grateful that you were willing to share your vulnerability tonight and share your story. So thank you.
You're welcome.
I'm going to turn this over now to Kelsey Kyle, RN Care Manager at St. Peter's Medical Health Group. And I know that I think she's sitting with Sheri because of some issues about joining, but so I hope she's on. There she is. She's not Sheri Walker, but she's Kelsey Kyle. So Kelsey, can you tell us about your work as a care manager at St. Peter's at the medical group there?
Yes, good evening, everybody. I'm Kelsey Kyle, and I have been working at St. Peter's Health Medical Group for the past 3 years as a nurse care manager. And the best way to kind of put a nice little bow on what I do is that I help people that need extra care and support, connect to resources, help navigate through the medical system, and then especially those that are struggling, just help them if it's with complex medical needs, people that are struggling with housing, food insecurity, paying bills. Our team's able to help people that are having depression, anxiety, or mental illness struggles. We're able to help connect them to the proper resources. And a big part of my population is working with moms, babies, and families, and just wrapping around support around all of the parents that really need the extra help, and especially if they find themselves in a place of struggle.
All right. So when a woman comes into your clinic in the perinatal period who is or may be severely depressed, tell us about how you go about your nursing assessment.
Yeah, so our clinic is using validated tools. Both the PHQ-9 and the Edinburgh are used in the clinic. And so oftentimes when somebody is referred to me, I am available for warm handoffs most of the time. And then sometimes I do get messages where I end up calling the patient. But if somebody's really having a hard time, the staff does their best to find either myself or one of my team members to see somebody in person. So that the depression screen is already completed. So it's really a kind of a two different paths. So one is if the mom has suicidal ideation, has marked those last questions on both screens positively, then my assessment is much like Dr. Caldwell had explained before. My next step for me is using a Columbia, sorry, my brain. So the Columbia tool, just to assess how how far away those thoughts were, if it's, today, 3 weeks ago, that time frame, assess if somebody has a plan and, the likelihood of them carrying out that plan. And then depending on that scoring, it would be completing a safety plan and having somebody, a plan that we feel good about, somebody going back home with support, or if they need to seek emergency care and look at hospitalization. So that's one path. The other path is having a situation of a mom who has significant depression and or anxiety with absent suicidal ideation, so no suicidal ideation present. So approaching that situation is really just meeting that mom where she's at. I can be a, kind of a happy, upbeat person, but, trying to like come across in a calm, compassionate manner, sit in a way where the mom feels that I'm really, listening to her and engaged. I also do work on the phone, so just really having quiet time to, to call and listen to somebody. And then just really a lot of times the screening tool is the start of a conversation for me. So I say things like, tell me more about your worry that you're having, or, what has your sleep been like lately? So just really trying to use some questions to get the mom to open more up about what's going on and just really listen to her story. Part of my assessment is listening for things that are strengths in her situation and resources that are already present and support that's already present. And then also listening to where there's some gaps and then what some options are for those gaps to present after, at a place where she's has told her story and talked about what she would like to. I directly ask about sleep and how she's managing with disrupted sleep. And I really normalize that that's very hard for anybody to go through. It's not like, I think there's can be sort of society saying, oh, moms can handle this sleep, or, pictures of new moms that look refreshed and their makeup's done and, look great. But in reality, sleep deprivation and disrupted sleep is very, very hard. And especially if it goes on for months at a time, it can be difficult to continue and just talk about how is she coping with that? Is she, needing extra help and support from family, friends, a partner, and what some options are. So some parents that I worked with set up schedules where they're able to have like one go to bed a little bit earlier than the other. And then, one person do a couple of feeds and then they switch in the night and kind of give each other, good 4 or 5 hour blocks of sleep at night. Some moms just need extra naps during the day and need that support. And especially if she's had a rougher night with baby. So just kind of working out, just talking through, what options could be and what might work for that individual person and family. And then I also ask about her support system and who can help, who she feels comfortable asking for help, and what items is she comfortable asking that specific person for help with. So, is she comfortable asking her mom to come over in the evening if there's, she needs to sleep, or baby's fussy or having a hard time, or, a different person, is it better just to like say, please bring me groceries or a meal? So just looking at, what strengths there are that way. I ask about if she's able to eat regular meals and snacks. And I find many women that are really struggling, the last person they're thinking about is themselves, and that can be a challenge. So just working on even starting with just small nutritious snacks and asking support people if they're available to help prepare those as well. And then I also ask about how feedings are going with babies, and this can be a source of struggle, no matter how you're feeding your baby, but just offering resources if they do need extra support, community lactation resources if mom's having a difficult time with breastfeeding, and then providing extra support if formula feeding, tube feedings, different all different scenarios that could possibly be going on if she needs extra support with that. And then I'm able to connect our patients to community resources, so our home visiting program, WIC, and those are kind of my top two, but we have other some other community resources. And then if a mom is needing some open to feeling like she needs some therapy, we have therapists that work within our clinic. I also help refer people out to the community, and especially with somebody who's really struggling, I will call therapists and see if they have current openings so that I'm not giving patients numbers and they're reaching dead ends, and when it may have already been a difficult thing to make that phone call in the first place. So just trying to ensure those things. We have social workers on our team that can help with any social determinants of health or instabilities with housing, food, transportation. If somebody's having a hard time affording medications, we can help with that. Hard time paying their electric bills or utilities. So just, all those things we can connect and just really, really help out a family.
Okay. Sometimes, as you know, Kelsey, a woman who may be suicidal may not be forthcoming or with her thoughts, or may not even answer on either the PHQ-9 or the Edinburgh that they're suicidal, but you may feel that, or you may be worried about it. How do you go about gaining her trust, especially when she may be reluctant to share with you her feelings?
Yes, that's a very good question, Dina. So I have such a huge heart, caring heart, lots of compassion and empathy, and really just, I feel like I have a gift with it, but I just really, really listen to patients, really meet them where they're at. I don't push people, but just provide an welcoming, open space that's safe for people to share as much as they're willing to or want to. And I find that pretty quickly, many patients will open up and tell me a lot of things that are going on. And sometimes with some, it takes, more than one visit or contact or outreach to get more of the story as well. But I've had really good success with, focusing on asking about sleep, especially like, how are you coping? And then really connecting with that patient and, validating, saying, yeah, it would be incredibly hard to do that. Or completely, it makes sense that you're really overwhelmed right now with everything that's on your plate. Or, just tell me a little bit more about your thoughts of worry. And I am able to get patients to open up. I think my most challenging situation in my time of work was I had a family member. So there was a patient that I had called after she delivered, and then so then she ended up seeing an OB provider for follow-up, and we didn't have contact with her. And when she was 4 months postpartum, her family member called our clinic saying that she'd expressed suicidal ideation to the family member, and they were really worried about her. So that was a very challenging call, but I just called and said, I'm, with the medical group and, her doctor, and I'm just reach out to this doctor's patients. And I spoke with you a couple of months ago after you delivered your baby. I'm just checking in to see how you're doing right now, and if there's anything that I can help you with. And her first response was, I'm fine and everything is going okay. And so then I asked her if she was open to completing an Edinburgh screen with me on the phone, and she was. And she admitted that she had suicidal ideation within that screen. And then we just talked through all of the different areas that she was struggling. And she was really opened up and told me her whole story, which was she had a lot on her plate, and able to get her connected with therapy and some help. So it is, it can be challenging at times, but I think, for the most part, just really providing that space for people to share is important, and having a lot of compassion and empathy for them.
So in hearing Sheri's story, what might you have done to support her through the crisis? What would you have wanted to convey to Sheri to help her with her hopelessness?
So first of all, I just want to thank Sheri for sharing, because that's an incredibly brave and vulnerable thing to do. And just that I know it will help at least one person, hopefully many. But I would have just, really wanted to, I guess, like going back in time in the moment she was really struggling, just really listening to her struggles and those things that, led her to get to the place of having suicidal ideation, and, helping her find her anchor. She had mentioned her kids were really a huge part of keeping her here, and help her find the strengths in her situation, and the strengths in her support and the resources she had, and potentially looking at what was missing from her resources and what else could be added to help her as well. But then just really validate her story, and just try to just be with her, help provide hope that way.
Yes, it sounds like just the power of presence is really important. Yes. All right, so I'm going to now bring Pam Ponich-Hunthausen, LCPC therapist, into our conversation. Good evening, Pam. Please tell us about your current work as a therapist.
Good evening, and thank you so much for inviting me to be a part of this panel. I'm really honored to be here with all of you. So I've been in Helena for a while, doing a variety of work as a psychotherapist with children and families. I currently have a small private practice where I really specialize in trauma and parent-child relational issues, attachment, parenting, that kind of thing. Yeah, it's interesting having a small practice and how, different folks will be referred to me from all walks of life. But what I just tend to see coming in the door is women, a lot of women with trauma and some tough histories. I also work full-time for the state of Montana. I work for DPHHS for the Addictive and Mental Disorders Division. I am the Family Behavioral Health Program Manager and Liaison, which basically enables me to do a lot of wonderful things that I'm really passionate about with families and children, but more on a state systemic level. which is really exciting.
Okay. So tell us a little bit about your experiences you've had working with women in the perinatal period who were or have been suicidal.
So really the best answer to that is not enough.
Okay, all right.
You know, my experience now in my life with private practice, I tend to get women who have potentially gone through that in the perinatal period in their lives, but that was historical. It's not necessarily current. And hearing a lot about what survivors they've really been and how most often they had no help, nor did they reach out. So the more that I hear that piece of women's stories, the more it really tells me that we need to, as others have said, do a much better job of early screening and assessing and you know, and really offering resources and support to these moms and dads, because they're not immune. You know, during that time of pregnancy and a year after, at least. So along with that, I spent 10 wonderful years as the clinical director at the Florence Crittenton home, where Dr. Caldwell now is. And, you know, it's interesting when you're working with teenagers who have many, many risk factors, teen pregnancy being one, but generally a lot of trauma, substance abuse, potential, you know, child protective service involvement, as Dr. Caldwell said. It's difficult, it was difficult in those days anyway, for me to tease out or even necessarily identify if that's what I was dealing with when there was a mood disorder, because there's so many factors going on. And it wasn't really until I did some good training for myself and my clinical team in this area that I even really knew that much about it. And at that point, we really overlaid maternal mental health within that whole program, and every single resident was screened, and we really kept an eye on that a lot more.
Okay. So maybe we'll segue into that, you know, as we've been talking about risk factors, obviously, I'd like to know about how you see the role of adverse childhood experiences playing in triggering or contributing to suicidal ideation, maybe not just in the perinatal period, but obviously in any point in a woman's life as she's parenting her children. So.
Well, I appreciate you giving me that question, Dana, because I discovered the world of ACEs very early on, way back. Some of us might remember when I think Intermountain brought doctors and Folletti here to Helena to talk about the ACEs study. And at that point, I got incredibly intrigued by the research behind it, and have really been one of those therapists that use I use the ACEs questionnaire with all of my clients because it really informs so much, knowing a person's trauma history. And you know what we know from the research, that's such amazing, great, robust research. And what's come out of that is that, you know, for one thing, many of us have had adverse childhood experiences. It's a very common thing. And really, the more of those that you have, the more at risk you are for many things, many health issues, and certainly mood disorders, major depression, suicidality. It definitely increases the risk factor, which is why I really use that screener all the time. Because again, someone can be in my office and say, I'm fine. And you're going to get that, like others have said. And then, you know, I'll just casually say, you know, I kind of want to know some of your history. And, you know, then they'll give me their score of 9 or 10. And then I know a whole lot more about what's really going on underneath that. And as Dr. Caldwell said, I mean, when you have trauma in your history, that leads to a lot of different things, including the, you know, difficulty with relationships, difficulty with trust, so many other pieces too. So it's just really informative and I highly recommend that people don't shy away from that, using that. Super important to, I mean, knowledge is power, right? Both for the clinician and for a client. And, you know, as we say in the ACEs world, it's not destiny, right? It's adversity. So what do we know now that we know what your score is and what's been, you know, what's happened in your life, and how might that inform your potential for a perinatal mood disorder, a major depression.
Okay. And so when you're working maybe with anyone, especially women in your practice, because you do work with a lot of women and moms, whether or not they're necessarily experiencing a perinatal mood and anxiety disorder, but obviously have trauma, what are some of the therapeutic interventions you use?
Well, I have to say, although Kelsey is not a therapist, she certainly acts like one. Pretty much everything that she said nails it, I think, in terms of the way that I work as well. And it really is about, you know, creating a trusting, safe, holding environment for somebody. And that's difficult to do when you've just met them, obviously. As a therapist, I have the luxury of, you know, hopefully seeing them more than once. But, you know, even initially, it's really just about being, you know, obviously very non-judgmental, very accepting, very validating, and to be really real about that. I mean, because people know if that's genuine for you or if it's not. And I feel very passionately about helping women heal from their trauma, and whatever else they have going on with their mental health. And so it means a lot to me to really be there and create a holding, you know, a safe holding environment for them. And they get it. People get it. I also, when I meet the clients, I'll always say, you know what, this is you checking me out, me checking you out. It's not always a good fit. And it's totally up to you if you want to come back. And I think a lot of times just giving them that power, you know, empowering them, like, this is, I'd be working for you, you know, so it's totally up to you. And I'm here for what you need. We'll bring them back and I think help with the trust building as well.
Okay. So as you listen to Sheri's story, what were your thoughts and how might you have supported her through her crisis?
Well, I will reiterate also what Kelsey said. Sheri, thank you so much for being willing to honestly share that story. That's some tough stuff to talk about, and that vulnerability. So important as a part of your healing. So good for you. You know, I think, I mean, one of the basic things, and I do this a lot with clients, is when they say, you know, I'm okay, I'm fine. I'll say, how do you really feel, Sheri? Just like you said, right, Dina? You know, don't necessarily accept that, right? Like, you're in here for a reason. And the fact that you're here, I always applaud. Like, somehow you got here into my office. That shows a lot of strength. And I really applaud you. And, you know, I would really want to be working with Sheri on gathering supports around her as well. I think it can be obviously such an isolating, scary, lonely place to be, especially if you are a, pull yourself up by your bootstraps person from Montana, and also not used to relying on others. I just think I would stick with her. I would make sure she had good people around her. I would absolutely ask her very directly, because I think it's obviously very important to ask directly about suicidal thoughts and ideation and plan. If there were a group available, that would be a major go-to for me with clients with perinatal mood and anxiety disorders, because so often they do feel so much shame and guilt, and I shouldn't be feeling like this, and I've got these babies, and all the things that Sheri said, and that normalization with a community that gets it, super, super important.
Okay, so compassion, presence, non-judgmental approaches. So thank you, Pam. I would like to segue back, circle back to Stephanie and Dr. Caldwell very briefly, just for their thoughts, because they didn't hear Sheri's story ahead of time. So Stephanie, in listening to Sheri's story, what stands out to you in your research on maternal suicide?
I'll echo the sentiments. Thank you, Sheri. This is very, very brave and also stigma busting, which I think is a really important part of our work that we have ahead of us. I would say that the biggest thing that stands out for me is really, Sheri said something about, I wish someone would have asked me a more detailed question. And then as we're going through this, folks are talking about screening, and really that's what those screeners are. I think Kelsey even used the phrase, I use these screens as conversation starters. And so we can have these structured, poignant conversations, that does help us to dig deeper, whether we are sitting there as a therapist or if you're, WIC provider in the state that is now doing, a PHQ-2. And we have this understanding of what those questions might be helping us to, check for with that education about perinatal mental health. It really just emboldens me, or, bolsters me in thinking about how we can be more thoughtful about continuing to increase screening in the state, and how we can connect folks to the people that they need.
Okay, thank you, Stephanie. And Dr. Caldwell, as you listen to Sheri's story, how might you have worked with her during her crisis? What are your thoughts?
The part of me that's a therapist was thinking about validating her, joining with her, helping her to mobilize her support system. And the sort of analytical clinician of part of me was thinking about, what is this? There's a lot of signs of depression, staying in bed all weekend, a lot of tearfulness, a lot of insomnia, and I would have followed up on that. When did this start, and have this ever happened before, and did grandma have this, and what can I do about it?
Okay, so taking a full history of her symptoms. Okay.
Yeah.
All right, well, thank you. I think I wanted to just briefly ask, I know we're getting short on time. Did any of the panelists have a question for each other? Is there any question that you wanted to ask each other before we go to Q&A from the audience? Okay, I'm not picking up on anybody wanting to ask.
I wanted to ask Sheri, what was the most important thing that got you through that, and how did you get through it, and did you get help?
Yes, so I think initially what got me through was my overriding deep sense of wanting to live and wanting to be a happy mom and wife. But then one thing that, and having had a really good relationship with my provider. She was a physician assistant, and because of all my medical issues, I'd seen her regularly, and it wasn't ever a 5-minute visit. Both she and the physician that she worked under, I mean, you could expect to be in speaking with them for at least 20 minutes, if not 30. And so I already had a really good relationship with her. And she took the time on all those other visits to ask about what, was going on, and took the time to be personable and, how the kids and that kind of thing, but also not just to look at the symptoms and here's some medication for that, but just to kind of dig deeper and ask the questions that, and not just ask the questions, but also to let me take the time I needed to share what my experience, my symptoms were. And that day, I was really fortunate to get in to see her that same Monday that I called for an appointment. And she was really kind of on the edge, wondering if she should admit me or not. But because I didn't have a plan, she was willing to just let me go home and she switched up my medication. So I think that was one of the main things that got me through, was knowing that I could get in to see Christine and she had my back, and I had her cell phone number, and she made me promise to call her outside of office hours if I needed. And so I really felt supported from her.
Okay, thank you. Anyone else of the panel have a question for Sheri, or anyone else have a question for each other? Okay, so before we come to the end of our, is there anything else that you can think of that we may have left out that needs to be addressed? Or if you have any final comments or final thoughts or comments before we take Q&A. Okay, so for our participants tonight, there is a Q&A box, and you can ask us questions and we will try to respond to them. So I don't know if there's anybody right now who is, nope, I don't see any questions yet. So I will give it a few minutes. I know we ran over time, and so I appreciate everybody's patience with us, especially since this is the first time we ever did this, and trying to make sure everybody had a chance to share their thoughts and their experiences. So from Julie, she said, not to everyone, not a question, but Sheri, thank you. And I think we've had several thoughts about Sheri's vulnerability, being vulnerable and willing to share her story. So from Healthy Mothers, Healthy Babies to all the panelists, thank you so much. This was a really important discussion. Okay. Anybody else, even just thoughts from those who have been listening in? If you don't have a question. Oh, I do have a question. Here we go. We've got some questions coming in, so I will. Okay, so well, somebody just said, this was awesome. Thank you for all your stories. Okay, and so Matt Kuntz for Dr. Caldwell. Can pregnancy help bring on bipolar disorder?
So pregnancy doesn't cause bipolar disorder, but we think that the hormonal stresses of pregnancy and sleep deprivation and stresses in general and medical issues all can act as triggers for a given episode of mania or depression. And so the probably in pregnancy, it's the hormonal aspect, and in perinatal mood disorders, it's probably the insomnia, the stress, and the hormonal aspects that are the most important triggers for the perinatal mood episode.
And there's also a question specifically about the symptoms. So in perinatal bipolar disorder or pregnancy and maybe a bipolar episode, would you see either pole, both mania and depression, or mixed?
In my career, I've seen postpartum psychosis that represented mania. I saw a woman early in my career who'd had 5 children and 5 postpartum psychoses, hospitalized each time. Many of you have heard Melissa's story of her postpartum psychosis. And I've seen many more depressive episodes. And the symptoms are the same as any other bipolar depression or major depressive episode. In bipolar disorder, people are often sleeping too much, but they're very tired, down on themselves, feeling guilty, negative self-talk, low energy, nothing's any fun, hopelessness, pessimism.
Okay, all right. Are there any other questions or comments that anybody in the audience tonight or anybody else listening in who, oh, yes. So we have a question for Dr. Caldwell. Do you see patients outside of Florence Crittenden? I have a school who works with mothers of infants to 12 years, wondering if you would be a local resource.
I'm still unmuted. At this point, I am retired from the private practice, so I'm not available to take on new patients.
But I think she also said would you be a local resource?
I would be a local resource, yes.
Okay, all right.
I'm always open to questions or formal or informal consultation.
All right. So yes, so Adrienne, you could certainly contact Dr. Caldwell through this office. That number is 406-495-1515. And if you have questions about mothers of infants to 12 years, anything that he could offer as far as a resource, he can. So.
Oh yeah.
Okay. So anyone else, any other questions that we can take tonight? I'm not seeing any. Wait a minute. Oh yes, Sarah McConnell. What is the best advice for living so far away from family? So I think that might be directed to Sheri, maybe because you were living so far away from family.
Yeah, it's hard. I think if you can talk to them, FaceTime them. For me, I had to learn also to make family where I was. I moved a lot before I was married, and I kind of joke that I had a grandma wherever I lived. I adopted a lot of grandmas and a few moms along the way. So I think if you can, find 1 or 2 people that become like family, that can be very helpful. At least it was for me.
Okay. Well, thank you for sharing that. Are there any other questions? I'm not seeing any right now. I wanted to let everybody who is still with us that in the chat box, we have some resources that Oh, and I have some other things, some other comments. So I will give the comments first and then I will give the resources. But Emily Lucas, to all panelists and attendees, this was enlightening. Thank you so much. From Matt Kuntz, to all panelists, thank you for sharing your story and for the information provided. From Christina Fowler, to all panelists, what a great panel. Thank you all. Oh, so there is a question to all the panelists. What is the protocol for follow-up 6 weeks, 1 year, and are there follow-up with prenatal after birthing? So whoever would like to take that question, maybe Stephanie, because I know she knows a lot about the screening protocols and so.
I was going to toss it to Kelsey.
Oh.
Yeah, if Kelsey can answer that one, I think she's a fabulous.
Okay.
Living it right now.
So go.
Let's see. Okay, I think, can you hear me?
Yes.
Okay, I was being slow unmuting. Screening protocols right now. So prenatal should be 3 depression screens within pregnancy, so 1 every trimester. And then postpartum, 2 weeks postpartum and 6 weeks postpartum are, what's currently practiced most of the time. With clinics, there is a recommendation to extend that to every well child check for the first year of life, just because a lot of times, there's many times when symptoms of depression and anxiety will show up prenatally. It can also show up at the 2 and 6 week mark. But there's also times when those symptoms are delayed down the road, and especially if your support is stressed, your sleep is stressed for a long period of time, that can just add more weight down the road. And Stephanie had mentioned with her research too, like 9 to 12 months postpartum can be a pretty risky time for suicide and suicidal ideation as well. So I really think it is important to continue those screens out to a year.
Okay, thank you. I hope that answered the question. Anyone else have a question before we, I want to share some information we have. Just gonna check real quick to see if there's any other questions. No, I do not see any. And so we do have, in the chat box, we have a list of resources. We have the Suicide Prevention Lifeline, both in English and Spanish. We have the numbers. And for people who are hearing impaired, there's an online chat, suicidepreventiononline.org. We also want to let you know that Postpartum Support International has a helpline, both in English and Spanish, and a place to text that. There's a crisis text line as well. There's the National Domestic Violence Hotline that we have in the chat box. And if you're not in crisis but need additional support, we have a Montana Warm Line here in Montana. That we also have Healthy Mothers, Healthy Babies. We have NAMI. Am I missing anything, Stephanie? Because I don't see it. I just see part of it, but not the whole thing. So.
Yeah, let me throw in the learn more piece, but I got some resources from the state as well. And so I'll throw in those pieces on their kind of Organization for Crisis Response resources that look different across the state.
Okay. So we have 2020 Mom. I really encourage people to visit their website. They have a great website, Postpartum Support International, NAMI, Healthy Mothers, Healthy Babies, and then the Crisis Systems Information and Resources from DPHHS. So thank you so much. I want to thank everyone for joining us. I know this was a longer evening than maybe we had planned. I want to thank my esteemed panelists and colleagues, and certainly I want to thank Sheri for really sharing her story tonight and being vulnerable with a very difficult story to tell. I also want to thank Gary Mihalish from Helena NAMI and Tim Lewis for his support in the technical aspects of our webinar. And I really hope that this conversation tonight has helped to bring a greater awareness that maternal suicide needs to be a part of the larger conversation of the public health issue of suicide in this country. Suicide impacts us all, and moms are not immune, and maternal mental health matters, and that suicide is preventable and treatment is effective. So thank you, and good night to everyone. And again, thank you so much. I appreciate it.
Thank you, Dana.
Thank you.
Okay, so long. I'll
Thank you, Dana. Thank you all. Good evening.
Yep. Good evening. Good night.
Thank you. Good night.